All right, welcome to season 2 of ICU Doc Talk. I took just a few weeks break, and now I'm back. I'm in the outside playing with my daughter, while my wife takes a much earned nap. And I thought I would. We're also hanging out with a bunch of turkeys out here, like 10 of them. Anyway, so you might hear my daughter, who's adorable and starting to talk here in the background. Anyway, so welcome back. Thanks for listening. Today, let's talk about all of the terrible things that can happen in the operating room. Mostly, I want to kind of like educate and also maybe dispel myths. Knowledge is power, and knowledge gives people the ability to be confident when they're going in the operating room. So as an anesthesiologist, I've seen, just about everything that can go wrong in the operating room. We're going to talk about all the things that go wrong and what we do to fix it. And I will definitely be sharing stories from my experiences of things that go wrong and what happens. So let's do it. It's going to be fun. Okay, and this is not going to be an exhaustive thing of all the things that can go wrong in the operating room. I'm super distracted through most of this podcast playing with my daughter, which is fine. And so I'm not going to go over every single little thing. And I haven't planned out an outline here, so this is not in any particular order. This is just me talking off the top of my head. So I think let's break it up into 3 categories of anesthesia, and the things that can go wrong in those 3 categories. Again, this is not exhaustive. I'm not going to cover everything, obviously. But the 3 categories are going to be, it's going to be 4 categories, okay? It's going to be induction of anesthesia, maintenance of anesthesia, emergence from anesthesia, and immediate post-operative period. Okay, so induction of anesthesia, maintenance of anesthesia, emergence from anesthesia, and then the immediate post-op period. So that's, an anesthesiologist or a nurse anesthetist is covering, those, and also there is pre-op. Things can go wrong in pre-op as well, but I won't cover that. So these 4 categories. Just to be clear, induction of anesthesia is when we are, it's what it sounds like, inducing anesthesia. You're giving the drugs that are taking a person from wakefulness into anesthesia. And I'm going to be mostly talking about general anesthesia, but I might get into moderate sedation, deep sedation stuff. Maintenance of anesthesia is when someone is now under anesthesia and they're being maintained on a steady course of an anesthetic medication, and they're having a surgery done, and that's all the intraoperative things that can happen there. Emergence from anesthesia obviously is emerging, taking from some deep sedation or general anesthesia to wakefulness, and then the immediate post-op period is someone is still kind of groggy, they're waking up, and then the things that can go wrong there. Things go wrong in all of these 4 stages, and they're very unique. So let's start with induction of anesthesia. So when we induce anesthesia, it's a dangerous part of an anesthetic. It's one of the most dangerous parts of anesthetic, taking someone from wakefulness to deep sleep. Sorry. Because the medications that we're giving can be considered can be considered toxic, they're poisonous to your body. And one of the main things that many anesthetics do, like propofol and other medications and volatile anesthetics, is they drop your blood pressure. And they drop pretty much everybody's blood pressure when we induce anesthesia. Now, they may not drop everybody's blood pressure because a healthy person can have compensatory mechanisms to increase their blood vessel and tighten them up right away. But it fairly reliably can drop a lot of people's blood pressure. Some people it's profound, some people it's not profound. Sometimes if someone is healthy and has a healthy heart, it's no big deal. Maybe their blood pressure barely drops at all. Maybe if someone has a really bad heart to begin with and you induce anesthesia, that hypotension, that low blood pressure can be enough to kill them right on the spot. So being unstable after induction can definitely happen. And it can happen to a varying degree depending on what's going on. So, someone having low blood pressure after induction, very common. Sometimes it's inconsequential, sometimes it's extremely consequential. So with induction of anesthesia, someone can be hemodynamically unstable, and it can cause a lot of problems. Someone can have an arrhythmia with induction of anesthesia, meaning they go into an unstable arrhythmia, the conduction electricity of their heart just doesn't do well. Someone can go into like atrial fibrillation with rapid ventricular response, RVR. Sometimes that's consequential, sometimes it's not. Sometimes some people walk through the door with AFib, so it's not a big deal. You can go into SVT, supraventricular tachycardia, VTAC, less common, but you can also have unstable rhythms with induction anesthesia, which I've seen. You can have heart block happen, which is also an unstable, it's not a rhythm, it's like the absence of a rhythm. I mean, it's a rhythm, but it's a conduction delay. If you recall from other podcasts, I've talked about, the conduction of your heart starts in the atrium at the top, and it conducts down to the bottom into the ventricles. Heart block is where that conduction gets disrupted. And anesthetics can sometimes disrupt that conduction. And I don't think the mechanism is very well understood, but general anesthesia in general can cause heart block. And I've definitely seen heart block happen. I've had to cancel a case, like I see heart block right, after induction, and it's unstable, and I have to put pads on the chest and maybe even start pacing them and cancel the case. Because when these unstable things happen, when something wrong happens in the OR, you have to communicate with the surgeons, and you always have to be asking yourself, can we proceed with this operation? Where are we in the operation? Can we cancel it? Can we proceed? Is it the best thing to proceed? Are we in the middle of it? Are we at the end? This is a conversation you need to have with the surgical staff. They need to be looped in, and they are. Obviously, they're right there, and everybody needs to make this decision together about what to do. It's not just, it's a collaborative decision. But you definitely, when something happens and you're unstable in the operating room, you often have to cancel the case. And sometimes that happens right with induction. I've seen it many times. Another thing that can happen right away, that's rare, but is one of the things that we talk about a lot, is anaphylaxis. Anaphylaxis is a type of shock. Oh, she's getting excited about something. So anaphylaxis, ¿qué te pasa? Okay, one sec. All right, we're good, sorry. So the reason I bring up anaphylaxis during induction of anesthesia is that is typically when anaphylaxis happens. Because we are giving, there's two culprits of anaphylaxis in the anesthetic world. You can get anaphylaxis from a lot of different medications, but the two most common are usually an antibiotic or one of the paralytics we give, usually rocuronium. And then antibiotic is, typically Ancef in the United States, we use, cefazolin is what it's called. But those are the two culprits that are usually going to be causing anaphylaxis. And we give those at the beginning of a case during induction or soon thereafter. So anaphylaxis is one of those things that can go wrong, that can happen in the operating room, that I've definitely seen. And the way you manage it, for one thing, you have to be aware it's happening. Your suspicion has to be, you have to be on guard that it's happening. So when I've given, or the nurse anesthetist in the room that I'm covering has given, we're 10 minutes into the case and has given a whole stick of something like ephedrine or phenylephrine, which are vasoactive chemical drugs that we give that raise the blood pressure. If someone's given a whole stick of that, like a syringe, like a 10 cc syringe, which is whatever, I don't need to get into the doses. But if someone's given that in 5 minutes, I'm like, whoa, why is this person constantly in shock? Why are we constantly needing to bring their blood pressure up? That's weird. And then the other things I look for, what's going on in the ventilator? Are they having, is their airway starting to swell up? So despite the fact that you have a breathing tube in, you can still have your airway tighten down below, around the breathing tube and below the breathing tube. And when that happens, the airway pressures go up, and we are measuring your airway pressure. So I can see, we can look on our ventilator and be like, whoa, the pressures are up. The airway pressures are up. Why are they up? And they're in shock. The next thing I do is I immediately look at the skin of the patient to see if they're having a rash. And then if they're having a rash, it's like, oh, okay, I would definitely confirm anaphylaxis. Now, you can have anaphylaxis and not have a rash. And I would just treat empirically, meaning I suspect it. Maybe I haven't confirmed the diagnosis, but I'm going to treat it anyway. And how do you treat anaphylaxis? How do you treat it? Epinephrine. Right, that's the main, we all know that. That's why people that have a anaphylactic reaction to bee venom, they carry an EpiPen, which is epinephrine. And she's getting excited because we saw a dog and we're trying to chase it down. Anyway, don't get me started about epinephrine and how incredibly cheap it is to actually make, and then the prices of EpiPen. It's, morally reprehensible, but I digress. Anyway, you titrate in, you bolus epinephrine for anaphylaxis. I usually start with 10 micrograms, and I go up from there. I titrate to effect. if someone truly has anaphylaxis, epinephrine has a half-life of like only a few minutes, like 2 or 3 minutes. It dissolves or, gets metabolized in the bloodstream. So you have to start epinephrine infusion. You give Benadryl, you give steroids, you send off a tryptase, which is a compound that's released from your inflammatory cells that can be a marker of anaphylaxis. And so that later that person can have allergy testing to try to target what it was that caused them anaphylaxis, so that they don't get anaphylaxis again for the next anesthetic. Oh, we found the dog. She's very excited that we found the dog. Anyway, let's move on. All right, the next thing that can happen during induction anesthesia, I'm definitely not going to be able to cover a lot of stuff because I'm already 10 minutes into this and I've barely even cracked the surface of anything. But anyway, the next thing that comes to mind is difficult airway. So, we do an airway exam, meaning we look at you open your mouth, you move your neck up and down, you stick out your tongue, we look at your teeth, all that stuff. We listen to your lungs. And we get an idea of if you're going to be someone, when we say a difficult airway, we mean trouble, having difficulty putting a breathing tube in your trachea, through your vocal cords and down your windpipe or your trachea. So an unanticipated difficult airway is something that is actually pretty rare. Oh, hang on. She was upset that we had to say goodbye to the dog. So I was talking about difficult airway, and you don't necessarily know if someone's going to have a difficult airway before you send them off to sleep, paralyze their bodies, and then take a look. So it's rare, but every now and then you can, give someone a sedation, whether that's propofol, and then paralyze them with whatever, and then take a look, and suddenly their airway is hard, and you can't see what's going on. You can't see the airway; it's not straightforward, and you're like, "Whoa, I need to bring in more advanced instrumentation to try to secure this airway." So sometimes, if we know someone has a difficult airway to begin with, like they have a goiter, or they have a tumor in their larynx, or they're extremely obese, like a BMI of 70, 80, 90, 100, which is a very high. A BMI, I talk about it a lot. I know a BMI is a very crude measurement, but there are certain BMIs that get high enough, and that's going to correlate with very likely difficult airway. So when someone has an anticipated difficult airway, sometimes we do an awake fiber optic intubation where we keep the patient breathing spontaneously awake, and then we use a fiber optic camera to secure their airway. Now, the reason I bring this up is when someone has a surprise difficult airway, sometimes you have to bring in a fiber optic to secure their airway while you're keeping them ventilated, or we use video laryngoscopy. Anyway, there are different instruments that we use to secure someone's airway. And when someone has like a surprise difficult airway, and we can't put in a breathing tube right away with a simple dull blade called a laryngoscope, and that we have to step it up to like a video laryngoscope. Sometimes we have to step that up to putting in an LMA, a laryngeal mask airway. Sometimes I have to intubate through that using a fiber optic camera or fiber optic loop through the nose or something. Anyway, or a bougie. I won't get into the weeds of it, but there's different things we can use. Okay, sorry, I had to stop. My little girl was like, "You are done talking to that thing." Okay. So I was talking about difficult airway. I'll just finish that off. So some people can have difficult airways that are unanticipated, and that's something that can go wrong during induction of anesthesia. I would say not being able to secure someone's airway, meaning put in a breathing tube, is extremely rare. It's very rare. I've only had if you can't get a breathing tube in and you do all these other things and you still can't, then you have to do an emergent cricothyrotomy, which is cutting a hole in someone's neck and putting in a tracheostomy. I've had to do that one time in my career. So other than that, and that honestly, that wasn't even my airway. I've never lost an airway in my career. It can happen. But it's something that's rare. It's not a complication that you really need to worry all that much about. Unless you're someone that has a difficult airway, you have like a tumor sitting in your airway, then, long discussion with your anesthesiologist before you go out to sleep is very necessary. Okay, I just wanted to mention one more thing that can happen during induction of anesthesia, and that's bronchospasm. Bronchospasm, I've noticed, is one of these really under-recognized, underdiagnosed things that happens. I've seen it so many times at this point, I know it. I smell it in the air. So I'll send a patient off to sleep, put in a breathing tube, and, turn your back to look at the computer, chart something, whatever. And it's this combination, like the alarm, a pressure alarm goes off, like the patient's coughing, and then they're desatting, and then I see that they're moving a little bit, and I'm like, I know they're bronchospasming. So bronchospasm is basically like, just what you think of like someone with an asthmatic attack. The conducting airways of their lungs squeeze down, they seize up, and then we have trouble ventilating them. And it happens
often after induction, after instrumentation of the airway, when we put a breathing tube down to the trachea, we stimulate that airway, and it's all like, it's reactive, and it starts to seize up. Because your conducting airways have muscle. They have smooth muscle that constricts and relaxes. So anyway, the algorithm to treat it is actually very simple, but you have to recognize it. You got to recognize bronchospasm. And if you're someone who works in the OR, listen to the patient's lungs. If you're like, what is going on? You increase your FiO2 and all that stuff, but listen to the patient's lungs. You have to listen to the patient's lungs. And you hear wheezing, but sometimes you'll hear almost nothing. Sometimes you hear no ventilation because the bronchospasm can be so bad that you're not even moving air, so you can't even hear anything. So, once you recognize bronchospasm, it's very simple. And I do this every time. I'm like, okay, grab some albuterol, which is a bronchodilator, and put that through the breathing tube circuit. Sometimes if the bronchospasm is so bad and you're not ventilating, you can't even get it into the airway. But anyway, you do that. You deepen your anesthetic, meaning because the person is light, and when they're light, that's when they get more of a reactive airway. So you deepen your anesthetic, give a bolus of propofol or whatever, go up on your gas, and then I almost always at this point drop epinephrine, IV epinephrine, because it's like a silver bullet. If you recall, that stimulates your beta-2 agonism of your smooth muscles of your airway, and it relaxes your airway, epinephrine, which is like adrenaline. So I always draw it up. I dilute it. I usually take a code dose. I unpackage that, which is 100 micrograms per cc, and I dilute that to 10 mics per cc, and I titrate in 10 mics at a time. And 10 micrograms of epinephrine, and a lot of people are like, whoa, that's pretty, I can't believe you're already doing that. I'm like, no, I just give it right up front. I want to break this bronchospasm because bronchospasm can get real bad real fast. So I give 10 mics per cc, 10 mics per cc concentration, and I give 1 cc at a time, and I titrate that in. 10 mics of epinephrine never hurt anybody, even if their blood pressure, heart rate goes up a little bit. You're not going to hurt them, unless obviously they have like an unsecured cerebral aneurysm or something, but whatever. Anyway, you do that, and then I think I've talked about it before. If someone is bronchospastic, you also need to be like, are they having anaphylaxis? You got to rule that out as well. All right. Oh, I'm already 17 minutes into this. I've only covered induction stuff. Many other things can go wrong during induction. Why don't we move on to what did I call it? Sorry, I recorded the first part of this episode like 2 weeks ago. I'm having trouble remember. I call it maintenance. We're doing 3 parts, right? Induction, maintenance, and immersion. So let's talk about maintenance of anesthesia and the things that can go wrong during maintenance of anesthesia. Oh, okay. I just went and looked back and I saw I did 4 categories. Immersions. Sorry, I'm such a scattered. This is just whatever. Anyway, this is what you get. You pay what you get for with this podcast. All right, so maintenance of anesthesia. I'm going to just right away talk about malignant hyperthermia because I know a lot of you are probably like, talk about malignant hyperthermia. So malignant hyperthermia is a very rare autosomal dominant genetic disorder. If one of your parents has had malignant hyperthermia, you have it. That's like a guarantee because it's autosomal dominant. Anyway, I won't get into the genetics. You don't want me to because I can't talk about that intelligently anyway. So malignant hyperthermia is very, very rare. And it is a genetic defect in how calcium is released in your cells when it's exposed to very specific medications that only we give in anesthesia world. And they are very specifically volatile anesthetics like isoflurane, desflurane, or sevoflurane, and then also the paralytic medication succinylcholine. Those are the triggering agents that cause malignant hyperthermia, and nothing else. It's just those things that cause it, and it causes too much calcium release from a part of your cell, your cells, and it causes you to be hypermetabolic. So the metabolism of all your cells goes off the rails. Your cells start producing way too much energy. You get hyperthermic. That's why it's called malignant hyperthermia. Although hyperthermia is a late finding of malignant hyperthermia. If you're waiting for someone's temperature to go up, they likely already have had, to diagnose it. They already have ongoing malignant hyperthermia. It's hypermetabolic. When you're hypermetabolic, what happens? You start producing too much carbon dioxide. Your body, it'll happen during anesthesia sometime. And again, it's so rare, an anesthesiologist or a nurse anesthetist can go their entire career without ever seeing this from one of their patients. That's how rare this is. One of the first signs is increased end-tidal CO2. The body starts expelling a ton of carbon dioxide. And if that's happening inexplicably, you're like, what is going on? Why is there so much carbon dioxide? Why do I keep having to adjust my vent settings, like the respiratory rate and the minute ventilation or the tidal volume to compensate? And if you keep doing that, that could be an early sign, one of the earliest signs of malignant hyperthermia. Malignant hyperthermia is deadly. It needs to be treated immediately with dantrolene. And, the surgery needs to be canceled if it can in that moment, and the patient needs to go to the ICU. If right off the bat, if you suspect someone has malignant hyperthermia, call the malignant hyperthermia hotline. Just Google it, malignant hyperthermia hotline. You will get someone on the phone immediately that's going to help you. So this is like a free service. I don't know who funds it, who pays it, but it's because this is so rare and it's so deadly, and people don't see it very often. You can kind of forget what the signs and how to treat it. And if you're in doubt, if you're a question, you can get someone on the line right now, an expert that is guiding you while you're while you're treating a patient, talking with you, helping you. So if you suspect it, call them and they will help you. It's an amazing service that any provider can use, and it's free. Now, if you're suspecting malignant hyperthermia, obviously you want to cool the patient. You want to stop your volatile anesthetic right away. Switch it to something else like a propofol infusion or whatever else. Communicate with the surgeons directly. You're worried about renal failure. You're going to send off labs, and this patient needs to go to the OR. And then dantrolene immediately. You get any hospital. Inpatient hospital setting should have dantrolene available, and that is the antidote for malignant hyperthermia. And then once this can only be diagnosed with a muscle biopsy. So you suspect it, you treat it, the patient goes to the ICU. They often need dantrolene for sometimes hours to days, and they need to be cooled, like actively cooled, like ice or electronically cooled blankets, whatever. And then that person needs to get a biopsy to confirm, and then all of their family that's related to them should also get a genetic testing to see if they have it, because if you have this, you need to know that you have it, so you can communicate with your anesthesia staff if you have surgery, because it can be very, very deadly. Anyway, that's all I'll say about malignant hyperthermia. There's obviously more to talk about with it. So what are other things that can, basic things that can go wrong during maintenance of anesthesia during routine surgery? How about bleeding? People can bleed out. A surgeon is cutting your body. A surgeon is harming your body, right? Obviously, you're there for a good reason, but a surgeon is doing like terrible things to your body. Either they're hammering, or they're sawing, or they're cutting. And while they're doing these things, they can cut into veins and arteries, and you can start to bleed out. Now, you have about the average, human has about 5 liters of circulating blood volume. Like right now, you have about 5 liters of blood that's circulating through your body. You can lose all that in just a few minutes. If you have an open artery, even a small artery, you can lose all of that blood in 3-4 minutes, and you're dead. Obviously, you're dead. So surgeons, obviously, they're very, very aware of bleeding, right? It's like it's their main thing. Oh, patient's bleeding. So if they rupture a vessel or something, or lacerate a vessel, they're right there. They can put their finger on it to stop it for a minute. While they get control of the bleed. Right? It's not like it's a super uncommon thing for there to be an unexpected bleed, but this is what surgeons do. It's their trade, right? So they're very good at controlling bleeding. But there are times where it's difficult. It can be extremely technically difficult to get control of that bleed, or where is the bleeding happening, right? To identify the bleed. And that's part of the anesthesiologist's job. Our job is to be like, if your vitals start tanking, your heart rate goes up and your blood pressure goes down, and we can be like, whoa, what's going on down there? It's nothing. It's not anything we're doing up here, we don't think. So are they bleeding? It's something, a conversation with the surgeon, and to alert them, and they're like, oh, maybe they are bleeding, and they need to look for it. While that's happening, sometimes we need to give you a bunch of blood products. Sometimes we need to give you a bunch of blood products very, very quickly. Sometimes you're limited by your IV access. We need to get larger IVs. Sometimes we need to put a central line in your neck while you're asleep, if these things are happening. Or we may anticipate ahead of time that this is going to be a large bleeding risk, and so we'll even have large IVs and central lines right after we send you off to sleep. If someone has a tumor that's being worked on and it's wrapped in a bunch of blood vessels, I'm probably going to put either very, very large IVs in you or a big central line in your neck so that I can very quickly resuscitate you. And then we have lots of different equipment to get blood in you very quickly. In the United States, we have something called a Belmont, which you can get tons and tons and tons of blood product in someone instantly, right? Like really, really quick. Like within a few seconds, you can get a ton of blood products within you. So bleeding happens. That's our bread and butter, right? In resuscitative medicine and anesthesia, that's our bread and butter, is treating someone who's bleeding out. Now, when I'm in the OR and I think someone is bleeding, there's times where you just give blood. You don't need to wait on getting like a blood count, getting a hemoglobin or hematocrit level. You just give blood. And it depends on, it needs to be a balanced approach, right? Red blood cells are balanced with fresh frozen plasma, and sometimes you need platelets. I often use TEG, thromboelastogram. There's also ROTEM. There's a lot of different ways to analyze what's going on. But I have no problem giving someone a blood product if I talk to the surgeon or look in the surgical field and I see bleeding, or I talk to the surgeon, I'm like, is it frank bleeding? Are they oozy? Do they look coagulopathic? And that's a very important conversation, and I will resuscitate based on what is clinically happening. Don't wait for a lab. You know what I mean? You don't need to wait for a lab to treat someone with blood products. All right, I'm actually going to just move on to the next things that can go wrong during emergence of anesthesia. There's a lot of things during maintenance, during the actual procedure that can go wrong. That can be very specific to the operation. And someone going to cardiac arrest any time during an operation, it's very rare. And that's a big part of our job, is just, resuscitating someone, chest compressions and all that, and running a code blue, what we call in the United States. So there are a lot of things that can go wrong during it. But during emergence, which I'll just move to just for the sake of to just move things along. So emergence is when we're turning off the anesthetic. Surgery's done, the patient is sewed up, and you're turning things off, and you're waking them up, and you're going to take out the breathing tube. A lot of things, so you've probably heard anesthesia is a lot like flying a plane, right? So when the most dangerous parts are takeoff and landing, induction and emergence. That's when, sending someone to sleep, putting a breathing tube, and waking them up and taking out a breathing tube can be very dangerous parts of anesthesia. Things that can go wrong are, you extubate them and their airway, they're not able to protect their airway, or they can have bronchospasm when you extubate them, or they're obstructing when you extubate them, or they have residual paralysis on that hasn't been adequately reversed by us, the anesthesia team, right? We give paralytic medications, and if they still have a little bit of paralysis on board, they're not able to move their diaphragm and have, actual good work of breathing. So that can be a big issue. There can be delayed emergence. Someone just won't wake up, like, for a while. And that is a broad differential. Maybe they're hypoglycemic. Maybe they, took their long-acting insulin in the morning. They didn't eat anything, and nobody got a blood sugar, and now their blood sugar is 30 or 40, and they're not waking up. So having that, delayed emergence, maybe they had too many opiates on board, and they're not waking up enough, and maybe we need to give Narcan at the end of a procedure. That's something that can happen. And if that happens, if you have to give Narcan, if someone got a little bit too much of opiates and you have to give Narcan, it's not like oh my gosh, what have we done? Every now and then, you got to reverse it. Ideally you shouldn't, but usually it doesn't result in a adverse patient outcome if you have to give a little Narcan at the end of a case. Although it should not be part of your anesthetic plan, to give Narcan to reverse the things that you've done. Now, assuming you can get a breathing tube, you wake up someone appropriately. To take a breathing tube out of a patient, they need to prove that they're breathing on their own on the vent. We're not giving them too much support from the ventilator itself. They need to follow commands. And usually in my practice, I ask, open your eyes or give me a thumbs up. And if they can do that, I know they're safe to have the breathing tube out, because if someone can follow their commands, their airway reflexes are back intact, and they can protect their own airway. So they have to prove those things. And that's why you actually can have a memory of the breathing tube coming out. Most people do not, but you can, because you technically need to follow commands before we can take it out. One thing that can happen is if the breathing tube is taken out a little too early. There's different stages of anesthesia. And if we take it out there's a certain stage that's very quick, where you go from deep anesthesia to being awake. And it's called, stage 2 or phase 2 or whatever. It's an excitatory stage where your reflexes are they're very easy to be excited. What I mean by that is, if you stimulate someone's airway, meaning you take out a breathing tube during that phase of anesthesia, you can cause laryngospasm. Laryngospasm is where the larynx, or the throat, seizes up as a reflex, and then that person is now breathing against a closed, larynx, and it's a reflex. They're not doing it themselves. They're just trying to breathe, and they can't, and that's called laryngospasm. What can happen about that is, if you breathe against a closed space, like a closed larynx, and you breathe really hard, rather than drawing air in, you can draw fluid into your lungs, and that's called negative pressure pulmonary edema, and that can happen during this phase, which is something that is usually self-limited, meaning it goes away, but it can be a problem for that patient's, outcome. So laryngospasm can definitely happen. It's something that's always on a radar. It can happen to anybody. The treatment it's pretty easy to recognize. That's why if you take out someone's breathing tube, you have to confirm. You put a mask on over their mouth and nose, and you have to look to see that they're moving air after you take out a breathing tube. So you're ruling out laryngospasm. If someone is laryngospastic, it's pretty straightforward how you treat it. You give a little positive pressure to try to break it. You can give a little propofol to try to relax those cords. Sometimes you have to give a little succinylcholine to relax those cords as well, which is a paralytic. So laryngospasm is definitely something. It's not super uncommon either. You can see it all the time. It's usually because the provider has taken the breathing tube out too fast. But also it can be taken. It can happen with just very normal, good standard care as well. So laryngospasm is one of those things that can happen. Now, moving on to things that can happen in the fourth stage of this, things that can happen in the recovery unit. So there's, in the United States, we call it the PACU, the post-anesthesia care unit. I guess that's what it's called, PACU. I just always call it PACU. I forget what the abbreviation is. So that's where you take a patient directly from the OR. That's where they're immediately recovered by a specialized PACU nurse. Things can go wrong in the PACU, and an anesthesiologist is still available to treat those patients. So part of my job is, I supervise in my practice in the United States. Practices vary widely for anesthesia. In my practice, I supervise up to 4 nurse anesthetists in an operating room. I do not sit the case myself. It's not just a one-on-one. It's me supervising and in collaboration with my nurse anesthetist colleagues, working with them. Anyway, but part of my practice is also seeing all patients preoperatively, that I can go through those 2 to 4, whatever, ORs, and then taking care of them afterwards. So problems that can happen are, post-operative pain, very common. If you know my content, I'm very pro treating someone's pain. If they're in pain, I give you pain medication. I give you opiates, whatever you need. If it's ketamine, whatever. Nausea is extremely common. There's many, I should do an entire podcast about nausea medications, because that's a huge thing in and of itself, the pharmacology of anti-nausea meds. We have many tools in our, drugs in our toolkit we can use for that. There's other things that can go wrong in the post-operative. It's like someone is not really waking up. They're like kind of comatose. And so, a PACU nurse will alert me being like, this patient's not quite working up. Just yesterday, I had a patient not quite waking up enough. Sometimes that's just delayed emergence, kind of what I was talking about. They're just, we got the breathing tube out, but they're still just like, they're not perking up enough. And they're like, what's going on? So you got to make sure, you do a good neurological exam. Has something happened? Was this a neurological procedure? Did they have something done in their brain? Because they could be having a post-op bleed. I had a patient a few months ago who had a brain tumor taken out, and they were, and then they were comatose in the PACU, and we highly suspected a brain bleed, which they did have, and they had to be rushed back to the operating room to open that, by a certain neurosurgeon to open up and relieve that bleeding, that is not like the fault of the neurosurgeon. That's just a post-operative complication that can happen. If a surgeon operates on your brain, it could bleed, just soon after, unfortunately. So you have to rule these things out. The context is everything. What surgery did this patient have, and what is the complication that they can have? Like, do they have a thyroid removed? And now are they in the PACU unit and they're having trouble bleeding? Well, they can have bleeding, or they're having trouble breathing, excuse me. Well, maybe the sutures of the surgical site around their neck is now bleeding. They have a huge hematoma. It's compressing their airway, right? So you have to be, I'm always very aware of what surgery did this patient have. Why are they, and then, I was talking about delayed emergence. Maybe they have too many opiates on board again. Maybe they had too many benzos. Do they need Narcan? Sometimes they give IV caffeine. Sometimes people are just a little too comfortable. They're not like apneic, like they're breathing okay, but they're just not waking up enough, and give IV caffeine. It's a great tool. It just perk people up. Now you got to rule out other stuff before you give IV caffeine. You got to make sure nothing major is going on, like a stroke or a brain bleed, or that they're hypoglycemic, or that they're having a seizure. Do they have a seizure history? Some of our medications can lower the seizure threshold of patients, and you got to be like, wow, are they having a seizure, kind of a subclinical seizure? You just got to be very, very aware of all these things, and that's why an anesthesiologist must be immediately available to assess post-operative patients, because things can go wrong there as well. Arrhythmias, right? Someone being in new heart block, someone being in new AFib or A-flutter. There are just so many things. I know this has just been a random splattering of things that can happen in the anesthesia world. There's so many things that can go wrong all throughout this course. And that's what it's a huge part of an anesthesiologist's job, and a nurse anesthetist's job, is to figure these things out and to fix them. An anesthesiologist's job, I always say, ultimately is being an expert in crisis management. That's our job. Walk into a patient's room, maybe knowing zero context, and something is going extremely wrong, and it is an anesthesiologist's job to fix that. We are experts in crisis management and resuscitative medicine, and that is our job. That is why you have an anesthesiologist covering your case, is to get you safely through it, and in case something goes wrong, it is ultimately our responsibility to fix what's going on. Anyway, I think I'll sum up that discussion there. There's a billion more things I could have talked about, and that was a pretty truncated version of actually what I really set out to say. But time is not always on my side. So let's move on to the book that I want to talk about this week. This week we're talking about American Sickness, How Healthcare Became Big Business and How You Can Take It Back by Elizabeth Rosenthal. This book was published in April 2017. It's about 650 pages. It is absolutely a must read. You need to read this book. If you're an American, particularly, you need to read this book. So this is the book to read about the commercialization and exploitation of American healthcare system by hospitals, by private insurance, by pharmaceutical companies, and by medical device manufacturers. The author goes into painstaking detail about the bloated, deprived, and egregious state of the American healthcare system. For me, as a double-boarded ICU doctor and anesthesiologist, this book just had me screaming, just seeing red. So it's about, as I said, it's about 5 years old, this book. So hopefully a lot of the facts presented here are more commonly known. But this is a treasure trove of information that you need to know. So the U.S. spends about $3 trillion a year on healthcare, which, to put that in context, that is the entire economy of France. We have skyrocketing costs without patient health improvements and with worse outcomes. And the only returns on the costs are the ones rigging the system and padding their pockets with the outrageous profits. There are several issues here that have led to this dire state. And there's more. I'm going to kind of itemize it. So number one is our monopolized healthcare system. Their stranglehold on the market allows them to bully insurance networks into paying large sums, which completely destroy the finances of the underinsured or the uninsured. Nonprofit status of hospitals allows them to dodge payroll taxes, compensate their CEOs as much as or more than private-like companies, and invest in curbside appeal for their hospitals to help with their optics to keep patients coming, like having beautiful lobbies or paying for a bunch for art and being a nonprofit. So number two is monopolized private insurance companies. They have the ability to act unilaterally and stop reimbursement whenever it is not profitable. A lot of that has to do with the McLaren-Ferguson Act that doesn't treat private insurance as interstate commerce, so it doesn't have as much antitrust ability for antitrust legislation. I'm surprised she didn't talk about the McLaren-Ferguson Act in this book, but I suggest you do look into that. Anyway, number three, pharmaceuticals and their patent evergreening. By adding like another atom to an old drug, they can repatent that same drug and then charge whatever they want. And the generic market doesn't mean prices get cheaper. A pharmaceutical can monopolize a generic drug market and then take over the prices and then just skyrocket them up. Number four, medical manufacturers are like a cartel. They have a hold on their products and their pricing, and there's like 3 or 4 major medical device manufacturers, and they do whatever they want with the pricing and are heavily involved in bedside patient care. Heavily involved. They are standing over the shoulders, literally, of surgeons and consulting with them in real time during your operation about what screw to put in. Put in this thing, put in that thing, and it's screws that cost whatever, $1 bazillion that they are influencing a surgeon's decision. That's just one example. So number five, there's contracting upon subcontracting within a hospital system. Many hospitals contract services out like lab work, pathology, or anesthesiology, and these companies charge whatever they want, and they can be out of a patient's insurance network, so they have to foot the bill. So if you've gotten a surprise bill, and you're like, why? A lot of times it's because it was a contracted service. It's something that was out of network. And that brings me to number six, out of network costs. These creep up on patients out of nowhere when they get their bill. Number seven, doctors. Doctors can be clueless about not knowing about costs. They can order redundant diagnostics that are not needed, that could be outsourced, and subcontracted services. And then there's also profit-seeking doctors that set up exploitative practices and ethically questionable ownership relationships. Number eight, the unbundling of healthcare. Everything now costs something, including the IV bag, an IV push, a cotton gauze. Everything costs something. And it's also that hospitals can nickel and dime whatever they want. And they do this so that they can make up for costs here and there, and then inflate a price here or there, and then insurance will pay for it because they don't want to be kicked out of the network. Number nine is a lack of price transparency. Patients should have financial consent. So you have to give consent before you have a procedure. You should have to give your financial consent. Everything should be laid out beforehand, exactly what it's going to cost your insurer and you before you get a procedure. Price volatility. Hospitals employ strategic pricing, which I just talked about, which creates insane pricing volatility. There's upcoding of medical diagnoses and nickel and diming everything that is done to a patient to extract as much profit as possible from the process. Number 11, exploiting resident doctors. Residents are underpaid for their labor. And of course, this is not equivalent. One thing that kind of bothers me, so residents and doctors make this like, oh, residents are underpaid for the labor. Of course they are, but it's not equivalent to a different profession being underpaid, because residents become full attendings who eventually have higher salaries. So it's not the same thing. The residents should be paid more, don't get me wrong, but we need to stop making this parallel between residents are very unique labor class, right? Extremely unique. You can't make a comparison to other people that are underemployed in other professions. That kind of bothers me sometimes. Anyway, the point is that resident labor is very profitable for hospitals because they receive, for one thing, they paid, they get dirt cheap labor and very, pretty specialized labor, and they receive government stipends for having residents that they may not use all of that money to pay the residents. And why do they need the stipends when they have plenty to pay their CEOs multi-million dollars and they make their lobbies look pretty? Why do they need that stipend? Why? Number 12, the AMA, the American Medical Association, is a completely out-of-touch, rent-seeking body of bureaucrats who lobby for their own bottom line. The AMA no longer has the patient's interests at heart. It acts like a type of Senate with extremely unbalanced representation between medical specialties, ensuring that subspecialties like ENT or urology are better compensated than other specialties like internal medicine or psychiatry. The AMA has many, many revenue streams, of which only 25% is made up from physician membership. And to be very clear, I am not a member of the AMA, and I don't plan on ever being one. There are so many other reasons enumerated in this book that I don't have the time and energy to talk about. You just need to read this book. Why our healthcare system is in the United States is 100% broken. The amazing thing about this book, American Sickness, is that the author spends several chapters offering solutions, many of which are about educating yourself as a patient. You should ask for an itemized bill every time. Ask if some of your care is contracted out, and if those contracts are within your insurance network. Ask if your doctor has ownership in a surgery center or anything else that they are referring you to. Not-for-profit hospitals, maybe they should lose their status if they can afford to pay CEOs more than private companies. We need stricter regulations on drug patents. Medicare should be expanded to the young. Medicare is more efficient than private insurance. Medicare spends 98% of its premiums for medical care and only 2% for administration, which is way different when it comes to private insurance. Private insurance is a bloated, inefficient beast. It's the exact opposite of what people think. People imagine, Medicare is a government agency, it must be a bloated bureaucracy. It's actually the private sector in this that is a bloated bureaucracy that is just completely rent-sinking and just extracts profit. The ACA, otherwise known as Obamacare, was mostly a gift to private insurance, but there were helpful provisions that can be built upon. The author really gives a lot of solutions, and you just got to read this book. You do. It's a phenomenal read. And as a physician, I highly recommend you read it. Educate yourself about the catastrophe of American healthcare industrial complex. And that catastrophe, just to be clear, what is the catastrophe? It's access and it's costs. That's the catastrophe. It's not the actual quality of healthcare. American healthcare quality is very good. It's some of the best in the world. But it's the access and the costs and the distribution that is an enormous human catastrophe. All right, I don't have time to do any questions today. I'm sorry about that. So I'll wrap this up. Thanks again for listening. This is the season 2. Let me know. My email is icudrecmo@gmail.com. Please email me with questions, concerns, feedback, or ideas for things to talk about on this podcast. Please share and please read a review. Help the podcast to grow. I think the information I'm sharing here is unadulterated. It is not influenced by any financial backing or financial interests. I don't have any advertisers. It is purely me. So share it. Help it to grow, because I do think advertising and marketing helps something grow, but I don't want this to be this is not a profit thing for me. So if you like this podcast and you want people to hear it, the only way it's going to grow more is if you share it with people. You right now. You who is listening to this, if you share it and leave a review, that helps it to grow. Anyway, but who cares if it doesn't? Whatever. I don't. It's up to you. If you whatever. Anyway, I'll see you next week. Thanks.